Good afternoon and welcome everyone. My name is Jerry Taylor and I'm one of the co-chairs for the ACHA COVID-19 Task Force. I'm also an associate dean for a former associate dean for health counseling and wellness at Bentley University in Waltham, Mass. This is the second of our Ask the Experts series. 2 weeks ago, we covered wastewater testing, and the link to that recording can be found on the ACHA COVID-19 resource page. That page also contains all the latest updates. Be sure to check your weekly ACHA COVID-19 update emails. There's tons of useful information that will hopefully help you as you deal with this situation. Also, continue to use ACHA Connect. So many of you have been helping each other through that site. Now, 2 announcements. Registration is now open for the ACHA Health Equity Summit later this month, and registration for the second COVID-19 Virtual Summit, December 8th and 9th, will open soon, so stay tuned for information on that. Today, feel free to type in a question in the Q&A pane on your screen, at the bottom of your screen. We'll try to get to everyone's questions. One last item, we're recording the session, and the recording and the link to the slides will be sent to all registrants as well as posted on the ACHA COVID-19 resource page. With that, let's begin. I'm so pleased today to introduce our 2 speakers. Melissa Nolan is an assistant professor and clinical epidemiologist in the Department of Epidemiology and Biostatistics at the Arnold School of Public Health at the University of South Carolina. Her interests lie in infectious diseases and health disparities. Her work focuses on patient-oriented public health approaches to tackle diseases that disproportionately affect the impoverished. Giang Nguyen is a family physician who's executive director at the Harvard University Health Services and is the Henry K. Oliver Chair of Hygiene at Harvard University. Dr. Nguyen also serves on the board of directors of ACHA and is a member of our task force. So welcome everyone today, and thank you for joining us. Now I'm going to turn the program over to Melissa. Thank you so much, Melissa.
Thank you, Jerry, for the opportunity to be here today. It really is a pleasure. When this was all coming about, I think the reason I was asked initially was that I've been had the good pleasure of serving as the co-lead for our public health and medical future planning group at the University of South Carolina. So I've been in the thick of this since the beginning of March, really trying to identify a lot of the questions that you guys probably have, so hoping to share some of that. I'm also an active researcher, and one of the projects I have right now is looking at viral kinetics among pregnant women and looking at transmission to their infants. So I've been doing a lot of testing in that regard. So I believe I'll give a talk. I'll hand it over to Dr. Nguyen, and then we'll certainly entertain questions at the end. Thank you. So next slide. So the first just overarching fundamental aspect of detecting pathogens when we think about diagnostic tests is that depending on the course a person is in their infection, you're actually looking for different targets. So initially, you have your incubation period, which means when someone is first exposed, there's a small window in which any test result is not going to be able to identify anything because your body needs time to develop enough of that pathogen in it before you could detect it. And this incubation period is different for each pathogen, but we know that for SARS-CoV-2, it's really anywhere from 4 to 7 days. So we would tell people that they should generally wait anywhere from about 3 days to 7 days after their believed exposure before coming in for a first test. So as you can see in that purple line, the first thing that you're going to start detecting is going to be the actual virus itself or the antigen, and I'll discuss those differences in a second. And then towards the later end of that, you're going to start looking at your antibody response. So your IgM is that first primary antibody response that you would see. That typically starts to be detectable anywhere from a week to 2 weeks after initial infection. And then later in the course of disease, you'll be looking for the IgN or IgG antibody. Next slide, please. So today I'm just going to highlight a couple of the basic testing platforms and assays that we're using to identify this infection in our populations. I'll tell you a little bit about the basics of how they work. and talk about sensitivity issues, specificity, and then some other just kind of pros and cons with each of them. So PCR, we really consider that to be the gold standard right now for SARS-CoV-2 testing. So traditional PCR is going to give you a positive or negative result. Either you have the virus or you don't in the system. The general concept of how that works is there's 3 steps. So first you're going to do the denature. So that's where we take that helix structure, we separate it apart. Then you do your annealing step where you have that primer that's specific for your pathogen that'll attach to it, and then it makes copies. So that's your extension. And you go through cycles and rounds of this. So qPCR, which is your quantitative PCR, also sometimes called your real-time PCR. It's the similar platform. The difference is that it can actually give you a quantitative number. So instead of saying yes or no, you have the pathogen, it can give you some indication of how possibly infectious someone is or how much viral titer they have beyond just infection status, yes or no. And the concept with this is that the result comes out in what's called your CT values, your cycle threshold. And this is an inverse relationship. So the smaller your CT value, the higher the number of virus you have. And so with that, think of this as the number of cycles that we have to go through that 3-step process before there's enough of that pathogen to detect it. So if we need, for example, let's say your hypothetical threshold was 100. If you're starting out with 50 copies already of that virus in your body, you could very quickly get up to that threshold versus someone that's starting out with maybe just 2 copies of the virus. It would take more cycles for them to get up to 100. So the highest, the CT value that I've seen that would indicate the highest amount of virus titer was 12. Just to give you an idea, that's not common. We normally see them more in kind of the late 20s, early 30s range, but anything over 40, we would not consider that to be diagnostic. At that point, it would likely be non-specific, indicating that you're detecting some other type of viral presence. So you really want to use kind of 35 as your cutoff value. So anything above 35 would indicate that you have a positive value. And just to kind of identify and let you know some conversations that we're having among the academic community, we think that we could use these CT values to give us an idea of whether or not someone's infectious versus just being diagnostic. And we could also use that to correlate possibly to what their clinical outcomes are. So as I mentioned, a lower CT value would mean there's more virus in the body. And so we would think that would correlate with worse health outcomes. But what I can tell you is that on our campus, the person that had the highest amount of virus ended up being someone that was asymptomatic and had actually just run 8 miles that morning. So it can be very tricky to always use this. But as a general rule of thumb, we would say that someone that has more virus, a lower CT value, could possibly be associated with a worse health outcome, which could help you to prioritize what their clinical needs might be. With PCR, we can use a variety of different samples. We can use the nasopharyngeal swab, which is, they like to call it here, the brain twister, the brain bleeder. It gets really far up there, as you likely know. You can use an oropharyngeal swab, which is going to be in the back of the mouth. Saliva is another commonly used one. There's also self-collected nasal swabs. And then you can use other biologics. You likely wouldn't need these for your campus environment, but in the hospital system, we could actually detect possibly virus within the placental tissue to give us a better understanding if mother has passed it on to baby. We could also look for it in the blood to see if there's any concern of sepsis. So there's been some conversation about what is the best type of sample for identifying virus, particularly among a community population. We know that saliva is very rich in those ACE2 receptors, and that's the thought behind why saliva might be a better sample. I can tell you in my research of the literature, it's very two-sided. There's some evidence that really suggests saliva is a better indicator, that it can pick up virus for a longer amount of time than a nasopharyngeal swab. But I think either way, both of them, if you're picking them up in the right amount of time in the infection, they're likely both to be positive. It's when you're on those two extremes. So when you're at the early phases of infection or towards the end, that's when you might have some challenges. So if that's a concern, that's something I think you would have to talk about on your own campus, which one you would prefer. What I can tell you is that in my experience, students much prefer to give saliva. So sometimes you have to think about what's going to best suit your population's needs. There's been actually several studies looking at the efficacy of a self-collected nasal swab, which is further down in the nasal cavity, versus the NP swab. And we've seen for multiple different respiratory infections that there doesn't seem to be too much of a statistical difference with that. I still believe that an NP swab is going to give you a better sample, mostly because it's traditionally collected by a trained person versus a lay audience. But again, I think that's a conversation you would have to have for your own campus. Next slide, please. So the inherent challenge with PCR is that we can't really say if someone is positive, if they're positive but infectious. So we know that people are shedding viral particles for a continuum of time. And I've seen in some of my patients that it could be up to 5 weeks after their initial positive test that they're still shedding this virus. So it could be really hard for us to see. And as you can indicate here, we know that your viral load tends to be highest when you are infectious, which is why the specific range of a CT value could indicate someone's infectious versus just shedding. But it's not a precise science, and we haven't been able to nail down specific numbers for that yet. So this is really part of the reason why we're not using testing as a way for someone to get out of quarantine or isolation. Next slide, please. So antigen detection is another commonly used technique that we're hearing more about, especially towards the end of the summer. It really began on our radar. Some of the benefits of antigen detection is that it can be noticed a lot quicker. So instead of looking for specific viral genetic material, you're actually looking for the proteins that are expressed by the virus. So you can think of this as, the external part of someone's body, right? So you're looking for their hair, for example, or for their facial features, if you will. So this is the expression of the virus itself. And so the glycoprotein spike, that one that we commonly think of, the crown, that's one that we really commonly look for. We can also use the nucleocapsid protein as another commonly identified one as well. The challenge with antigen detection, though, is that it's less sensitive, which means that we have more false negatives. And the aspect of that is our genetic material, so the primers that we're using for PCR to detect that virus, we can use really conserved sequences. However, we know that viruses generally mutate over time. They all do that. That's how they survive and evade our immune systems. But that really manifests itself in that outward protein expression. So think of that as there's just going to be small inherent changes, and those are more noticeable with the antigen. So that could be kind of going back to that same concept, hair, right? So a woman's hair color could change very quickly. I could get a box of hair dye tonight and I could be redhead tomorrow. So viruses, same thing. They can have these small changes that manifest more pronounced through their antigens. So that's why we think that qPCR really is better at detecting, just because it's picking up more conserved regions than an antigen. But antigens are great. Like I said, it's cheap. They're easy to use. You can use them in your clinical environment and can give you an answer within 15 minutes. Next slide. So I did want to talk about the BINAX now. I had the pleasure of meeting with Ambassador Birx and with Surgeon General Adams a couple weeks ago, and they both are really excited about this. So Abbott has created several different products for COVID testing, but this one in particular, they think is going to be really useful for kind of high throughput scenarios. So for going to concerts or for classroom environments. And so this is an antibody, it's an antigen test that is the size of a credit card. It's very thin. It's very similar to the others in that you'll take a swab, you'll put it in the reagent, and then you put that fluid onto this card, and then you can have a test result within a matter of 15 minutes. You can read it yourself visually, or you can purchase one of their kind of machines that you could stack them in for more of a high throughput. The benefit of this is that it links directly to an application on your phone, which could be used for scanning to allow people to come in and out. So if you are thinking about, I think some of the kind of uses, intentions for this could be for a graduation ceremony at the end of the year. If you want to be able to allow family members to come in, but you want to have a kind of quick, easy way to screen them, this could be, I think, an option for you. Again, they're very cheap. They're targeting at $5 a test, and they're trying to do 50 million in production in this month of October alone. Not that I am recommending them over any others. I just think that it's a really novel and innovative design that could have use for campus populations. Next slide, please. Okay, so antibody detection. Antibodies can be used as a way to identify active infection. It really isn't great. We would recommend that you use either that PCR or antigen test. But in theory, as you can see on this slide, so the IgM is going to spike early-ish in infection. Again, it's really about 1 to 2 weeks after that initial exposure and symptom onset that you'll see this. So it could give you an indication of active infection, but we really use this more to give us an idea of what the immunity is on our campus population. So IgM is the first one that you get, and then that actually undergoes what we call class switching, which then turns it into an IgG antibody. And that's when we think of that vaccine, it's that long-term response. So if you're looking for, most of the antibody tests that are out right now will give you both an M and a G together on the same platform. So if you have someone that's IgM positive, but G negative, that could be active infection. If you have both of them positive, you know that you're somewhere in the middle, versus IgG would be someone that has fully recovered. So that would be someone possibly from March, for example, that when tested in October should just have IgG, indicating, again, a full clinical recovery. Some of the challenges, though, is that with this virus, this is very unusual. We don't commonly see this. A large or considerable proportion of people that have been previously positive failed to develop a robust IgG response. So anywhere from 13 to 40% of people will have will not have IgG responses up to 2 months later. So for those that have seen kind of the clinical guidelines saying that you shouldn't have to test anyone within a 3-month period of an original test, that 3 months, though, we encourage them to then, if considered, possibly exposed or have any concern, if they don't have antibodies, they could get reinfected. We don't know at the rate at which we're truly seeing this and at what the rate of reinfection could be, but we know it can happen. I've had patients in my studies. We've also had students on campus that have gotten reinfected. So certainly something to monitor, and just be aware that just because someone tested positive in the past doesn't mean that they have a full antibody response a few months later. Another challenge with antibody detection, just from more of an operational standpoint, is that the reimbursement around this is constantly changing. And my understanding is that at the moment it's not covered by CMS. So these are about $100 a pop. So either your university, healthcare system, or the student themselves would have to cover the cost. One of the benefits of the antibody testing is that it is widely available. You can, most of the commercial uses, or most commercial industries have them. So your LabCorp, Quest should have them available. A fair amount of public health labs also have them. And then there are some great point of care tests, which are going to be a cassette. Think of that kind of similar to the antigen test. It's like a pregnancy test, if you will. It's very quick, yes or no, very clear to read. And that could be done with a finger prick versus an actual blood sample. Next slide, please. So I believe this is my last slide. I just wanted to talk about viral culture. The reason you probably haven't heard more about this, it's really one of the oldest diagnostic tests of all time. This has been around for a long time. The problem, though, is that for this particular pathogen, it has to be cultured in a biosafety level 3 lab, which there's just very few of those around. That's a higher containment lab. It takes time for the virus culture to grow itself, which can be challenging when we think about it from a university perspective, because you really need quick, prompt answers. However, it really is truly the only way to demonstrate infectiousness of a patient sample. So there might be times when you would feel it's clinically warranted to order a culture test, most likely through your public health lab. From an academic perspective, culture has great uses. So you might have people on campus that are wanting to request this, and they could use them for ways to help us understand how the virus works pathogenically. It can help us design better antiviral therapeutics or vaccines, or even to understand how stable the virus is under different environmental settings. And with that, I believe we'll go to the last slide. And I would just thank you all for your time. Here's my email. If you have other questions later on, please don't hesitate to email. Thank you, and I will turn it over to my esteemed colleague, Dr. Nguyen.
Great, thank you, Melissa. Really great information, and you know, these scientific advances are changing day to day, and it's very hard to stay on top of it all. And of course, in addition to the scientific information, we also need to stay on top of FDA approvals, emergency use authorizations, and so on. And so it's a complex landscape, and it's something that that we all need to stay very attuned to as the days go forward. Great. So my role at Harvard University Health Services is as executive director, and we have put together a complicated testing regimen for our community, and thankfully it has gone well. You know, I don't think that what we have done is that much different from what many colleges and universities are doing, except that perhaps we have done it at a larger scale in some respects than what others have. But that has provided us with an environment that I feel is pretty safe for our faculty, staff, and students. And but at the same time, it's important for us to remember that testing alone is not going to solve all of our problems. And I'll go to the next slide, please. So first things first, testing has to be part of a comprehensive strategy. It is only one piece of a very complex puzzle. So mitigation strategies are incredibly important. And in addition to testing, it is very important to make sure that our communities are using masks and other types of face coverings, that we are carefully following physical distancing guidelines. And that includes not only policies about keeping physical distancing, but actually going through space planning and considering how we lay out our physical spaces, removing particular seating arrangements, or spacing out tables and chairs and so on. That's really important so that we can give cues to our community members as to how far apart to be. And that also includes things like putting stickers on the floor so that people know where to stand, and putting signs up on elevators so that we aren't overcrowding them. In addition, engineering and ventilation and air quality, thinking about the quality of filtration, the number of air exchanges per hour in a space, all of this is very important in addition to testing. Because remember that at the time when someone gets tested, they might be negative, but they might have been exposed yesterday and simply aren't showing up as positive yet. And if you test them again tomorrow or the next day, they perhaps would be positive. So all of these mitigation strategies are important. And of course, a response infrastructure is critical. So if you're going to be doing testing, make sure that you have the appropriate spaces and protocols necessary to isolate people who are found to be positive and to quarantine those who might have been exposed. Think about the protocols and services for your students who are placed into isolation. How are you going to deliver meals? How are you going to handle laundry service and trash pickup and all of those other things? How are you going to address the mental health of your students who are in quarantine and isolation? And then, of course, case investigation and contact tracing is critical to the process of response to a positive result. And this might be done by the local public health authority, or that authority might have decided to partner with your university or college to do that work. In many ways, we find that individuals who work at a university or college are going to know the population better, be able to ask more informed questions and probing questions that will trigger memories in a way that other folks might not. And so having a partnered relationship with local public health in order to be involved in case investigation and contact tracing can be very helpful. But it is also incredibly time intensive, and you have to be prepared for that as well. And then finally, once we identify people who are at risk, it is important to have protocols in place to test those persons who need to be tested. Next slide, please. There are, of course, many factors that might affect your decisions about how to proceed with testing on your campus. And I know that many of you may have already gone through this process, so I'll go through this slide fairly quickly, but you need to think about your geographic characteristics. What is your local community transition? How big transmission? How big is your campus? What is the organizational structure and administrative structure of your institution, and who needs to be involved in these decisions? What are your funding resources? What are your student housing characteristics? Excuse me. Are folks on campus and off campus? Are they commuting? And it is always valuable to involve public health authorities locally in any decisions, and that collaborative relationship is critical. I think that many of our universities have existing collaborative relationships, and that's been valuable for us because having worked with local public health for things like mumps or meningitis, that allows those authorities to have an understanding of how colleges and universities work, and we can leverage those relationships now. Next slide, please. So before you implement testing, there are a number of specific considerations. So what are the availability of dedicated resources, and what logistics do you need to think about? How many trained staff will you need? Do you have enough PPE? Have you put together a PPE burn calculator so that you can decide the rate at which you need to buy more, and is it available? How are your supply chains? What kind of spaces will you need for testing? And what is your capacity to do required reporting, not only of the results to the individual, but also to authorities such as the Public Health Department? What is your capacity for following up? And do you have the facilities for isolation and quarantine, as I mentioned before? So there are also things like community transmission and risk of importation of the virus into the community, and having conversations with your local authorities and local community members is important so that they feel that you are not adding to the risk of their communities. Cost is really important to think about, and that will likely make a big impact on how you decide to test, how many people to test, how often to test, in addition to those normal public health thoughts. So I'm not going to read everything to you here, but you can see on the slide that there's a lot of things that we need to think about, and I'll just jump to the very next slide. When you're deciding who to test, prioritization is important, and the CEC has given us some guidelines on who to give greatest priority to. Of course, those who are exhibiting signs and symptoms of COVID-19 should be given the greatest priority. So if you have limited access to testing, these are the people that you need to make sure that by all means you test and that you provide those resources for. But then there's the category of individuals who are not known to be infected, but there is some reason that they're being brought into the mix for consideration, and that is if they are exposed, as suspected to be exposed, and if public health authorities or healthcare providers have referred them for testing specifically because of some concern, or in the event of an outbreak, is there some type of cohort level connection? For example, someone might not have an explicit close contact, but they are a proximate contact. They were in the same class, but they don't remember being close to the individual. But there isn't clear evidence that they are 100% sure that they were not exposed. So there are times when these individuals should be tested as well. Now, outside of that, there is screening. So we often think about screening at the time of entry, or perhaps right before entering a community. So students, upon returning to campus, might be asked to get a test right beforehand, or be tested on the day of return. And then there might be a two-phase entry testing where folks have to get an additional test, perhaps several days or a week later, to make sure that they didn't get exposed on the day of travel, because a single test at entry would miss that. And then there's random screening that might happen. So if you don't have enough resources to test every single person, you might do a random selection. And it's somewhat difficult to know exactly what percentage of the community you need to be testing in order to be the most effective. We do know from South Korea, for example, that they tested only about 0.5% of their community, but they did it in a widespread way, and were able to identify enough people to bring infection rates in their communities to be fairly low. Now, I'm not suggesting that we all only test 0.5% of our communities, because I think that we, in our campus communities, we probably want to be testing more than that. So that brings us to community-wide surveillance, and this means that anybody who is on campus should be tested. And if you have the resources to do this, then I would recommend that this is an outstanding way of keeping your community safe, because that really increases your chances of identifying infections early, probably during the asymptomatic or pre-symptomatic phase, so that isolation and quarantine and contact tracing can happen as quickly as possible, hopefully at a time when very few people have been exposed to that person and have been infected. Next slide, please. So there are a number of potential strategies to consider. You can offer testing at your student health center. You can test at freestanding testing facilities that are outside of the student health center, and but perhaps still run by health center staff. There is the option for observed self-collection, usually using those nasal swabs that were mentioned earlier. And then there is the potential, depending on what FDA authorizations you have, to do unobserved self-collection, and that's what we're doing at Harvard right now. So there are lots of options, and it all depends on the type of test you're using, the type of emergency use authorizations that test has, and what your capacity is. Logistical considerations should include things like your estimated throughput times. How long does it take to get someone through your testing facility? So that might require that you time people and identify bottlenecks, and then adjust your protocols in response to that. Estimating staffing needs are important, and also thinking about the PPE requirements and what exactly you need to use. Remember that when people are doing nasal swab collection, sneezing often happens, so you really do want to make sure that people are wearing the appropriate personal protective equipment when they are collecting specimens. Or you might use some type of PPE sparing approach, and I'll talk about that a little bit later. There are also language and technology barriers that you need to think about, particularly if you are testing faculty and staff and postdocs. There may be individuals who are not as fluent in English, and you need to be aware of that. And if you use technology in your testing approach, remember that not everyone has a smartphone. The IT infrastructure needs to be thought about, and partnering closely with your university's IT team is really going to make a big dent in what you need to do. And some of those things include result management and reporting and creation of things like dashboards. Having folks who are adept in the IT components of this are really going to be important. Compliance monitoring, adherence to protocols is really important too. You might tell people that you expect them to get tested every week, but how do you know that they are getting tested, and how do you identify folks who are not adhering to the recommended cadence of testing? I mentioned the idea of identifying bottlenecks and then changing your protocols. This use of a rapid improvement approach is very important, because we are all learning and building this as we go. And so a rapid improvement approach is really going to be necessary, and our teams need to be flexible. They need to be aware and ready for the fact that we are going to change the protocols at a moment's notice when we identify new areas of improvement. Remember that perfect is the enemy of good. We cannot be perfect in this, but we have to be just good enough to move forward, because if we wait for our solutions to be perfect, then we might be waiting too long. Next slide. So logistically, important for us to also think about things like signage, wayfinding, and crowd control. So this is one of our testing facilities at Harvard. Clearly, it's not very crowded at the time of this photograph, but there were times when we were about half full in this queue. And so making sure that you set up a system for folks to know where they need to go. And the stanchions here are actually about 6 feet apart, so that helps people to know how far apart to stand. Next slide, please. And then also leverage the use of outdoor spaces, because we know that respiratory droplets are not going to travel as far outdoors. So on the left side, we used the underside of our stadium at Harvard. And so this space was covered from the rain, although it did get a little bit windy sometimes. So we had to make sure we taped certain things down so they didn't blow away. But using those types of spaces is important. Sometimes you might need to set up tents. But also keep in mind that local regulations might limit how big your tent can be, how long your tent can stay up. So think about all of those things as well. And also not only think about heat and rain and cold, but think about the comfort of your staff and exhaustion, because they're going to be in PPE for a long time. So especially during the summer, that can be a problem. So you might need to make sure that your shifts are short enough to allow people to rest when they need to. And you may need Wi-Fi signal strength or access to extension cords and power, and all of this is important to think about, as well as parking, bike access, accessibility, and so on. Next slide, please. So I also mentioned PPE sparing approaches. This is at MIT, where they have a fantastic trailer where they do testing. And you can see that staff can enter this middle hallway where they're able to stick their hands through these little portals, and then the patient can stand on the other side, and then they can be swabbed. So this allows for the reduction in how much personal protective equipment is used by the staff and keeps everyone safe. So, so this is a really creative way of addressing that issue. Next slide. And then the idea of self-collection. At Harvard, we are using a process where folks are swabbing their own noses, activating their specimens online, and then going to various collection bins that are located all over campus. You can see all the stars indicating the collection bin locations. And so folks are able to do that on their own time, drop off their specimens, and then those specimens are then consolidated and sent to the laboratory. Next slide, please. Data management is very important to think about as you're planning this. So think about the mandated reporting that you need to send to local public health and state public health agencies. These are required by law. So if you are going to be doing your own testing, make sure that you are complying with all of those requirements. And the public also wants to know. So think about public-facing dashboards and what that will entail, and how much information you need to share there, and how quickly and how often you update that information. And then finally, there's internal monitoring. The administrative leaders, decision makers within your organization are going to need information in order to decide whether to pull back on certain policies or to strengthen regulations and so on. Next slide, please. So here's an example of a public-facing dashboard from the Ohio State University, and they are incredibly detailed in what they provide, but this is an excellent example of what you might see in a public-facing dashboard. You can see that there are daily cases, there are infection rates and 7-day averages, and they also are able to talk about things like equipment and cleaning capacity, as well as hospital capacity. Next slide, please. But you don't have to be that complicated in what you present. And so this is from Wheaton College, which is a smaller liberal arts institution, and they still got on Yale's Rate My Dashboard system, they still got an A on what they were presenting. And so this is not highly complicated, and it is enough for a community to understand what the situation looks like at your institution. And so you don't have to be overly complicated, but you just have to have a system that provides information. And there are actually many colleges and universities that already have this in place. Next slide, please. And then here's an example of what we have at Harvard for our internal monitoring. And so there are lots of things you might be thinking about. For example, are people attesting to their symptoms? That's sometimes a state requirement. Are people getting tested? How often are they getting tested? Are they complying with the required testing cadence? All of this information is important for administrators to know, and you need to be able to slice and dice the information so that subunits of your university can identify areas that need more attention. So internal dashboards that are not publicly available are important to add to what you're doing. Next slide. And I just list a few resources here. There are many colleges and universities that are already doing testing, so I'm sure that you can learn from colleagues who are already doing this. What I have presented here hopefully will help you think about how to improve what you are already doing, and if you're not yet doing it, I hope that this will be valuable as you think to the future. Thank you.
Thank you so much, Melissa and Giang. That was excellent. I'm going to try and rush to some questions. We got a number of questions as you registered for this event, and we also have some that came through the Q&A. I want to first ask Giang, what system and what test has worked the best for your campus so far?
So as far as system, wait, do you mean like what type of test we're using, or?
Yes, yeah.
Okay.
And
so,
how often, and how
sure.
often testing?
Yeah. So right now, there are many of us who are using PCR because that is the sort of gold standard, and it was the first to become available for many of us. And we use PCR testing, qPCR, and we're testing our residential community 3 times a week. And our students who are not living on campus are tested twice a week if they have any business on campus, like coming to classes or working in laboratories. The majority of our staff and faculty are tested once a week, and that is sufficient. But that is what works for us. We are basing those numbers for the residential community on models that were published in JAMA that say that testing every 2 to 3 days is ideal for a residential community. But we recognize that not everybody has the resources to do that.
And Giang, what's your turnaround time on results?
Our turnaround time is about 24 hours, but occasionally we do see some numbers that are longer than that, and we also very frequently get results back within 10, 12 hours. So if you are sending your results to the laboratory at rush hour, when everyone else is sending your specimens, you can expect that the lab is going to take longer to do it. And so we've tried to make sure that we space out our delivery times to the laboratory. We send our testing right now to the Broad Institute, which also is working with about 100 different colleges and universities in New England and some outside of New England. The vast majority of those institutions are all testing their students at least weekly or maybe once every 2 weeks. So they do very high throughput testing, but we're able to get our results quite fast.
One other quick question on this self-testing. I always worried that perhaps you couldn't trust a student, that a student might send someone else's result. How are you feeling about that? Is that working for you, or what are your thoughts?
Yeah, I mean, I think it's very easy for us to have a distrust of our community, but at a certain point you have to trust that the students are going to do the right thing, and that they actually want to know if they're infected, and that their parents want to know if they're infected. So so there's always that risk. We do know at least that it's a true human sample, because there are safeguards in the laboratory to assure that what we're getting is a human sample, but we're not going to be able to know that it belongs to a specific individual. However, if we start identifying clusters of disease where we are not trusting those results, we might be able to, we might have to switch to observed testing for a subset of community members. So far, that hasn't been necessary.
Great, thank you. How about you, Melissa? What's working at USC?
Yeah, thank you for the question. Our university president made a decision that everyone would be tested before coming back to campus. And so that was done through a variety of different mechanisms. Students had the option to either get tested at home and then upload it to their student health portal, or to get tested on campus. At this point, though, we are offering a variety of different mechanisms, but what's really working the best is our saliva testing program, and that is a PCR based. We're very fortunate that we had a couple professors here that had the foresight to get that up and running in collaboration with the Broad Institute as well. They've been in contact with them to have that operationalized for us. I acknowledge that might not be a reality for everyone. What I will tell you though is that we've started in the month of October. So we saw kind of a decline in our testing numbers after the first month of those being back. And so to help kind of robust that and to incentivize students to continue to come get testing, we're doing really fun kind of lotteries and different incentives throughout this month of October. So for example, we have these great shirts that were designed. We're giving those away for each testing event. They can also get enrolled into a lottery. So every time they get tested, they could get certain prizes, which were again designed by students. So being in contact with your student government is really important. Some of those are very simple. So a free parking pass for the spring semester, a free meal plan for the spring semester. They even said they wanted to get a personal tour of President Castle's house. So him and his wife are opening it up to that. So it doesn't always have to cost you a lot of money, but just trying to be creative in ways to get folks out. And we've had great responses to that in this month of October.
You mentioned, I want to go back to you, Melissa, the different types of testing. I've got lots of questions. People are asking when the BINAX is going to become generally available to the colleges. And then people have asked about the Sophia. They've asked about a couple of different types of COVID check Colorado, Quidel, BD. Do you have any information on those tests? Or first of all, when will it be available?
Yeah, excellent questions. I can tell you the Sophia antigen test was the first one to get EAU approval. Beyond that, I unfortunately don't work for any of these companies, so I can't tell you. Abbott is trying to get this out. They're already in production. Again, their goal is to make 50 million this month. I know what we've done is our procurement group worked very closely with a few different companies to try and acquire large groups of tests so that you might have to bulk buy some to get that supply in. But really what's worked best for us is also partnering with our local public health department, that they have these pop-up sites around town. So encouraging students to use those as well. And then as I mentioned, in addition, we have the option to do testing on campus.
Right, and I think partnering with public health is extremely important as well. Yeah. Let's see, we've got so many questions here. Testing asymptomatic versus testing symptomatic. We know testing symptomatic people is really the first line. How extensive are you doing it? How many people are you testing, Giang and Melissa, in terms of, maybe you can start, Melissa, is it every student? Is it part of the students? What group are you targeting?
How about I'll start it and then I'll hand it over.
Sure.
Is our experience, and this is not what everyone has to do. Important to us that we test people before coming to campus so that we knew at least we were starting off with a clean slate. What we're doing now is we're calling it testing smarter, not harder. So using just simple sample size estimates and power calculations, we've randomly selected a meaningful number of students. You don't have to test everyone. As Dr. Nguyen mentioned, other countries have kind of demonstrated that. You just need to test a certain number. And so that's one approach we're taking. We're also being really conscious to offer testing for students before they go home at Christmas, most notably for our minority students that might have, people living at home that could be high risk for transmission. So we want to make sure that we offer that as well.
When you say a certain selection, can you give us a percent that you test?
So for ours, yeah, and this is based on, again, some very basic statistical sample size estimates and power calculations. So for our campus uniquely, it was 1% had to be tested throughout and again, we're trying to do that throughout the month of October, but it could be different for each one. And I'd be happy to share some of those links and references for your website. And then I'll pass it over to Dr. Nguyen for his perspective on asymptomatic versus symptomatic testing. And you're on mute.
You're on mute.
Sorry about that. Yes, so for asymptomatic testing, we are basically going for every community member who spends a substantial amount of time on campus. So if someone is completely remote, so we have employees, for example, who are working from home entirely, we're not testing them. But if a person is on campus at least 4 hours a week, then we are enrolling them in the regular testing cadence. And so, for example, our residential community is probably around 3,000 people right now, and we are testing all of those people 3 times a week. And then for all the other, sort of most of our employees are weekly. But what we found is that if you make it as easy as possible for people to do it, then they don't have to work so hard. So having the self-collection where people are able to activate the kit themselves, they're given a number of kits every week, and then they could just work through those and test themselves at home and drop off the specimen. It has made it very easy for people to adhere to those recommendations.
Thank you. Can we jump to Melissa and just ask about sensitivity and specificity? Do you know, can you get that information on the BINAX? I think you might have mentioned it. I just want to repeat that if you did not.
Yeah, I would encourage everyone that's interested in this, as Dr. Nguyen mentioned, these are changing all the time. But so the FDA has a great website that shows the specific specificity, sensitivity, as well as your negative predictive value and positive predictive value. So it shows you all the different aspects of it, gives great detail for every individual test. I'd encourage you to go look at those.
Can you get that website to us so we can post it?
Sure.
That would be great.
Yeah.
Thank you. Let me see. What about the student that comes in with, respiratory symptoms and they're it's vague, they're in a gray area. Do you test them for COVID? And what about those who you test and they're positive fast test for mono or strep or for flu? Giang.
So I'm sorry, the question was, when do you decide to test for COVID versus for the others? Is that right?
No, when do you decide to test for COVID if you've got somebody coming in with very vague symptoms? Do you go right to the COVID or do you do the other tests first?
Right now, because our concerns are so high, we're testing anybody that we have symptoms that could potentially be COVID, because we know it's in the community. If it wasn't in the community right now, we perhaps would have a lower threshold, but we have access to testing, so we might as well be making sure that we catch it. Because we're also finding that there are quite a few people who have very vague symptoms that aren't necessary, that wouldn't make you think it was COVID right away, and then we test them and it turns out that they're positive. Now, of course, the percentage that actually ends up being positive for COVID is low, but I think it would be helpful to know.
What about the student who tests positive for, say, strep or mono? Would you also test them for COVID?
That's an interesting question. I think I would often leave it up to the clinician to make that decision based on the individual circumstances of that person. So if a person comes in with symptoms and they test positive and they told you, they had a roommate who had strep, there was, that we have a clear answer. It doesn't necessarily have to result in testing. And then of course, when you test someone, they become a person under investigation. You have to isolate them in anticipation of that result. So you do have to have a high enough pre-test probability.
We'll also let you know too that it's come out for the flu season. So I know LabCorp is already offering this, and then CDC is helping support that there's multiplex testing platform so that you can test with one sample a person for flu, for RSV, and for COVID at the same time. It's because we know that's going to be a challenge moving into this season. Certainly another reason to try and encourage all of your students to get their flu testing this year. but that is an available resource.
What about testing contacts? Somebody has asked that question.
What about testing contacts?
Yeah, which contacts are you testing? You know, is it if somebody's in a class, is it the entire class? Oh. Is it just the people who sat near that person?
So we're using public health guidance for our testing. So anyone who certainly meets the definitions of close contacts under 6 feet distance for 15 minutes or more, we are testing all those individuals. And then if it is a cluster where we have a greater concern, then we would expand testing to proximate contacts.
Any information on false positives and false negatives, Melissa? Are you seeing a lot of them, and how do you deal with those?
Excellent question. Again, unfortunately, there's so much variability right now with the tests that are on the market, particularly some of those that came out very early on. What I can tell you is that in general, the concern that we have with the antigen testing is that you could have false negatives, so people that really are positive but were negative on that. So if you still have clinical suspicion, we would encourage you then to test them for PCR. And then in general with antibodies, we can have the concern for false positives because you would have antibody testing sometimes is not very specific and you can pick up antibodies that are for another pathogen. But these are just generalizabilities. And again, I will be happy to share with you that information on those testing specifics for each thing that's available and on the market.
That would be great. We've got 4 minutes left. So I wonder if each of you could just give us, say, one tip for people out there who are considering testing or maybe want to get an ideal way of testing. Melissa.
Yeah, I think in summary, so and kind of just looking at some of the chats that's come up, I can appreciate that funding of this testing, of these different testing strategies is a real concern. We've certainly dealt with that as well. So I think, again, working with, trying to be smart about the way that you strategize it. This randomization could be a great way to do that, to give you good insight. Definitely having that message to your students that you want them to come forward and that it's okay to come to you, and building that trust with them. So working with your student governments to help spread that message so that students aren't afraid to come get tested. That's a good use of your resources. And then as available, working with your public health partners, your community, I can speak for us, we're an urban campus and our community is concerned. So they're here to support us as well. So there could be ways that you could leverage those community partnerships with your local public health office to help supplement some of your testing resources.
Thank you. And Giang, just a quick question on funding. This is very difficult. Do you have any suggestions for people? And also, what would your last tip be for our listeners?
Right. I think funding really depends on your individual organization and how their funding structure works. At Harvard, really, these costs are being borne by pretty much every school and unit across the university because it's a shared responsibility. And so I think that you just have to look at how your organization works and make sure that the top leadership of the university is involved in making these decisions, because it is a priority for the entire institution. My recommendations for anyone who's thinking about doing this is just to be realistic of what you expect of yourself and be cognizant of what the realities of your resources are, and to work with that. Don't try to expect more of yourself than the organization has the capacity to do. If you have a 1 or 2 person student health center, you can't be expected to screen the entire university on your own necessarily. You might need to get resources from the university to hire a contractor to help with some of these things, or maybe partner with the local public health and access some of the resources that the community offers. So there are lots of creative ways that can be that you can approach this with, but just be realistic and make sure that all of the stakeholders that you're working with understand the realities of what is necessary.
Great presentation, guys. Thank you so much. I think we've all learned a lot about testing, and I think the schools that are doing it have some tips on how to go forward, and those who aren't doing it know how to get started now. I wanted to tell the listeners that we will have another session on Ask the Expert on October 23rd, and that will be on the topic of quarantine and isolation management. And if you have suggestions for other topics, we do have a satisfaction questionnaire that's going to be sent to you, and it's only 3 questions, so we encourage you to answer that. Also, our survey is going out, our survey number 4. We've tried to make it as short as possible. Giang has worked with us on that as well. And your data is so important because with your data, we can see what best practices are and help other college health centers and yourself as well. So thank you for joining us today. And thank you so much to our presenters, Melissa and John. Thank you.